Assalamu alaikum. Good afternoon, colleagues. We have today one of important topics which we are facing in PICU and the critical areas, which is a septic shock, especially refractory septic shock, and how to manage using the fluids and the vasopressors. Last 2 weeks or last month, we have two cases of refractory septic shock, unfortunately passed away with multi-organ failure. This is why I prefer to present this topic. As an introduction, septic shock, which is characterized by severe hemodynamic failure, remains a major challenge associated with 30% to 40% hospital mortality, even though important therapeutic advances have been made over the past decades. Fluid administration is the first-line therapy, which aims at correcting hypotension and low blood flow related to both relative and absolute hypovolemia. However, as hypotension is also induced by sepsis-related systemic vasodilation, vasopressor therapy is fundamental in septic shock, aiming at correcting the vascular tone, depression, and then at improving the organ perfusion pressure. So our main target to improve the vascular tone to enhance the blood pressure and the perfusion to the tissues. In spite of recently published expert consensus statements on the use of the vasopressors in septic shock, controversies still exist on some issues, such as if very early use of norepinephrine could improve the outcomes, and whether individualized target of mean arterial pressure should be applied, whether vasopressin should be added to norepinephrine in the case of refractory shock, and whether novel agents such as angiotensin II could become of interest. So 4 main questions I try to answer about them. Which vasopressor should be considered in the septic shock? A large variety of vasopressors acting on different vascular receptors are available at the bedside. Among them, norepinephrine, which remains the most commonly used vasopressor and is recommended as the first-line agent by the surviving sepsis campaign experts. As a strong alpha-adrenergic agonist, norepinephrine increases blood pressure primarily through its vasoconstrictive properties with little effect on the heart rate, because it has mainly action on the alpha-1 receptors. Here, a table will show us the mechanism of action of the most commonly inotropic and vasopressor support we are using. The dopamine, according to the dose, if low dose used 1 to 5 mic, it has the dopaminergic effects, improving renal function. If 5 to 10, it acts on the beta receptors in the heart, and if higher doses, more than 15, it acts on the alpha receptors. Dobutamine acts on the beta 1 mainly. Epinephrine work on beta 1 and also has some effect on alpha 1 receptors. Milrinone and vasopressin has different mechanism of action, not stimulating any of the receptors. Norepinephrine is action mainly on the alpha 1 receptor and has some effect on the beta 1. Phenylepinephrine mainly on the alpha 1 agonist stimulation. Regarding the milrinone, it does not bind to beta or alpha receptors. It produces its effect through the phosphodiesterase 3 inhibitor, and the vasopressin acts through the vasopressin V1 receptor agonist. So the milrinone and the vasopressin not acting on the adrenergic receptors, either alpha or beta. Vasopressin is recommended as a second line. We said the first line is norepinephrine. Second line is vasopressin, is recommended as a second line vasopressor by the sepsis surviving campaign, despite the absence of proven outcome benefits in larger randomized controlled trials comparing vasopressin with the norepinephrine. A post-hoc analysis of the VAST trial found that vasopressin was more effective in less severe shock, where adding vasopressin to norepinephrine might help to reach the initial map target faster. The only benefit to reach the target map faster if added to norepinephrine. The sepsis surviving campaign has suggested adding vasopressin to norepinephrine, which is a weak recommendation, low quality of evidence, with the intent to raise the map to target or to decrease norepinephrine dosage. This could prevent the deleterious consequences of an excessive adrenergic load. And it will help to not to increase the dose of the norepinephrine, so it decreases the side effect of a high dose of norepinephrine. A meta-analysis of studies performed in patients with distributive shock showed a lower incidence of atrial fibrillation when vasopressin was added to norepinephrine compared to norepinephrine alone. However, this result was driven by one study performed in post-cardiac surgery. And some studies, meta-analysis, show that if I added vasopressin to norepinephrine, it will cause, it has low incidence of atrial fibrillation. If the vasopressin added to the norepinephrine. However, this result was driven by one study. This study only in a case of post-cardiac surgery. When only studies in sepsis were analyzed, no difference in the incidence of atrial fibrillation was found. Nevertheless, an individual patient data meta-analysis of 4 RCTs, including 1,453 patients with septic shock, showed fewer episodes of atrial fibrillation, but more digital ischemia when vasopressin was added to norepinephrine compared to norepinephrine alone. This meta-analysis, which also showed fewer requirements for renal replacement therapy, confirmed the absence of benefit in terms of the mortality. More recently, RCT conducted in cancer patients with septic shock comparing vasopressin to norepinephrine as the first line vasopressor therapy showed no difference in both cardiac arrhythmias and mortality rate. Since the response of adding vasopressin is difficult to predict in terms of potential benefits and toxicity. Agents that have selective effects on vascular receptors, such as tryptophan and celepressine, has been evaluated. And a large RCT conducted by Liu et al. Comparing celepressine to norepinephrine showed no difference in the mortality, but celepressine had more adverse effect. Here, they used another analog to the vasopressin, which is the celepressine and the celepressine. If compared to the norepinephrine, they mentioned that there was no difference in mortality, but celepressine has more adverse effects in comparison to norepinephrine. It is noteworthy that the long half-life of this drug, celepressine, has a longer half-life than the norepinephrine. The half-life is about 6 hours in comparison to norepinephrine, which is 20 minutes. But this is one of the side effects of the obstacles we are facing if we use this celepressine, a long half-life of the medication. Celepressine is a highly selective vasopressin V1A receptor agonist, and the animal studies using experimental models of septic shock showed that celepressine may improve several hemodynamic variables such as mean arterial pressure, cardiac output, blood lactate level, fluid volume, and the fluid balance, and may even reduce the mortality. However, in a recent large RCT with multi-center clinical trial performed in patients with septic shock receiving norepinephrine, administration of celepressine compared with placebo did not increase vasopressor-free days and the ventilator-free days within 30 days. So no major difference if we added the celepressine to norepinephrine. Epinephrine is another second line of vasopressors. And according to the sepsis surviving campaign experts suggested adding norepinephrine to norepinephrine, which is a weak recommendation, low quality of evidence, aiming to target MAP and reduce norepinephrine requirements. Annan et al. Comparing 2 vasopressor strategies, norepinephrine plus dobutamine versus epinephrine, in patients with septic shock reported no differences in both efficacy and safety. And a recent meta-analysis of 12 RCTs confirmed the equivalence effect between the epinephrine in one side and the norepinephrine plus dobutamine in another side. So if I will compare epinephrine or compare epinephrine with the norepinephrine plus the dobutamine. Due to its potent beta-1 adrenergic effect, epinephrine is more indicated in the presence of cardiac dysfunction than its absence. Nevertheless, epinephrine may have serious side effects such as tachycardia, tachyarrhythmias, and increased blood lactate level, which might be a confounding factor when interpreting lactate as a marker for the tissue hypoxia. It has to be noted that in the context of cardiogenic shock, epinephrine was shown to be associated with increased mortality. But they found if you use the norepinephrine in cardiogenic shock, there is high mortality in the patient with septic shock. And one of the side effects of the epinephrine, it can cause increase in the lactate level. So it will be a confounding factor in interpreting the high lactate in the tissue perfusion condition. So which is the cause? Is the tissue hypoperfusion or the epinephrine effect, the cause of the high lactate at that time? Angiotensin II, which is one of the non-catecholamine vasopressors, is a non-adrenergic vasoconstrictor that is the product of the renin-angiotensin-aldosterone system. A recent RCT showed that angiotensin II compared with placebo effectively increased blood pressure in patients with vasodilator shock, low wide pulse pressure shock that didn't respond to high doses of conventional vasopressors. Moreover, a non-epinephrine sparing effect was observed for angiotensin II compared to placebo. And if I compare angiotensin II to the placebo, they found a non-epinephrine sparing effect. It is noteworthy that in the trial, patients who required less than 5 nanogram per kg per minute to achieve the MAP target had lower levels of endogenous baseline angiotensin II than their counterpart in if it required more than 5 nanogram per kg per minute. Yani, there are two groups when they used the angiotensin II. The FDA used for the adult in United States, the angiotensin II, and given for some cases in the pediatrics. They found that if the patients need doses less than 5 nanogram per kg per minute, these patients have lower, who required less than 5 nanogram per kg, achieve a MAP target lower with a lower level of endogenous baseline angiotensin II in comparison to the patients who required more than 5 nanogram. It has been hypothesized that patients sensitive to low levels of angiotensin II, which is less than 5 nanogram per kg per minute, are more likely to have an angiotensin II insufficiency. Additionally, patients who required less than 5 nanogram per kg per minute had less severe shock because the patient has higher baseline MAP, maybe because they have another compensatory effect of the endogenous pressors as endogenous catecholamines, and lower baseline norepinephrine equivalent doses than those who required more than 5 nanogram per kg per minute of angiotensin II. Accordingly, the beneficial effect seen in these patients may support the concept of using angiotensin II earlier in the course of the disease. A recent literature review, including 24 studies, confirmed the effectiveness of angiotensin II at increasing blood pressure in all types of shock. When they used angiotensin II in all types of shock, it was beneficial. However, the angiotensin II for treatment of a high output shock trial was not designed to detect the survival benefit from the angiotensin II, and the concerns exist on its safety profile. Thus, further large studies are still warranted to clarify this issue. And they didn't study during this trial, the survival benefit from the angiotensin II. So we need more studies to give us the feedback. Dopamine was used in the past as a first-line vasopressor in septic shock. However, observational studies showed an increased risk of tachyarrhythmias and mortality rate. A large RCT confirmed that dopamine, compared with norepinephrine, was associated with more frequent adverse effects, especially tachyarrhythmias, even though no significant difference in the mortality was observed. Furthermore, a meta-analysis including both randomized and observational trials concluded that dopamine is associated with an increased risk of death compared with norepinephrine. And the latest sepsis surviving campaign guidelines recommended dopamine only in the case of bradycardia. Yeah, this is the only recommended condition if the patient has bradycardia. Taking all these evidence based on RCTs, norepinephrine versus dopamine, and norepinephrine plus dobutamine versus epinephrine, and the norepinephrine versus early vasopressin, they found that norepinephrine remains the first choice as a vasopressor in patients with septic shock. Vasopressin and the epinephrine represent the second-line vasopressor therapies, and the dopamine should be avoided. And the angiotensin II might be an alternative in patients with refractory shock. However, safety issues still needed to be clarified in the future. When to use vasopressors? Is it the earlier, the better? According to sepsis surviving campaign recommends applying vasopressors within the first hour when fluid administration is not sufficient to achieve the hemodynamic resuscitation goals. Recently, 34 experts from the European Society of Intensive Care Medicine have recommended starting vasopressors early, before full completion of the fluid resuscitation. Such a practice is still struggling to be implemented, as the majority of the intensivists start vasopressors only after complete fluid resuscitation or after checking that preload independency has been achieved. There are at least 5 major arguments in favor of the early use of the norepinephrine. The first one is early norepinephrine administration could correct the hypotension faster and then prevent prolonged severe hypotension. What supported this, and retrospective data shows that not only the degree but also the duration of the hypotension in the initial phase of the septic shock are key determinants of patient's outcome. And a recent retrospective study suggests that the time to achieve a MAB, which is 65 in adults, is shorter than norepinephrine is initiated within the first 6 hours of resuscitation compared to a more delayed initiation. And a recent single center RCT in septic shock showed that the time to achieve MAB 65 millimeter mercury, this is an adult, was significantly shorter when norepinephrine was initiated together with fluid infusion compared to when norepinephrine was initiated only if 30 ml per kg crystalloid failed to achieve the target MAB. So the earlier, the better. Second concern is the early norepinephrine infusion could increase the cardiac output through several mechanisms. One of them is that norepinephrine could increase the cardiac preload and reducing preload dependency at the early phase of septic shock by increasing the mean systolic filling pressure and redistributes blood from the abnormally increased and unstressed volume to the stressed volume through alpha adrenergic mediated reduction of the venous capacitance. And importantly, norepinephrine could be used to exert a synergistic effect along with the fluid infusion and thus enhances the effectiveness of the resuscitation. Additionally, norepinephrine could increase cardiac output by increasing the cardiac contractility. 3 mechanisms will improve the hemodynamics if I use the norepinephrine early. In patients with septic shock who have already received the adequate fluid administration, Hamzawi et al. Found that early norepinephrine administration could increase the lift ventricular ejection fraction, and the other indices of the left and right systolic function. Two mechanisms can be responsible for these effects, improving the cardiac output indices. One, improvement in the coronary perfusion pressure through an increase in the diastolic arterial pressure, because we know all that during the diastolic phase, the perfusion of the heart will occur through the coronaries. So improving the diastolic arterial pressure will improve the cardiac perfusion. And the second mechanism is the beta adrenergic stimulation of the cardiomyocyte, since at the early phase of septic shock, the beta-1 adrenergic receptors are not yet downregulated. So it has better effect on the beta-1. Third concern, early norepinephrine administration may recruit the microvessels and improve microcirculation in cases of severe hypotension through an increase in the organ perfusion pressure. Accordingly, Georgia et al. Found significantly improved tissue muscle oxygen saturation along with the increase in the MAP by norepinephrine from 54 to 77 in patients with septic shock. So it will improve also the microcirculation through improving the integrity of the vessels. And early norepinephrine administration also could prevent harmful fluid overload. It's well established that positive fluid balance is independently associated with worse outcomes in septic shock. In this respect, early norepinephrine administration could result in a reduced volume of infused fluids as reported by clinical studies, and thus in lower risks of fluid overload. So it will decrease the poor outcome of the high overload of fluids. And finally, early norepinephrine administration could improve the patient's outcomes. Two retrospective studies found that the time to initiate norepinephrine was an independent factor associated with mortality. So the earlier, the better. A recent single center retrospective study, RCT, including 101 patients with septic shock admitted to the emergency department, compared with impact on survival of the early norepinephrine initiation with late. If we compare the early norepinephrine initiation to the late norepinephrine initiation after the failure of 30 ml per kg crystalloid to achieve the target MAP, there is a significant difference in the in-hospital survival in favor of the early norepinephrine group was reported. So multiple benefits from starting early norepinephrine. The primary endpoint was the shock control at 6 hours from the onset, which was defined as MAP more than 65. This is for the adult with either urine flow more than 0.5 ml per kg per hour for 2 consecutive hours, or decreased serum lactate by more than 10% from the baseline. The main result was that 76% of patients in the early norepinephrine initiation group versus 48% only of the patient in the delayed norepinephrine initiation group achieved the primary endpoint. So the early initiation of the norepinephrine achieved the target lower MAP and improvement of the lactate and enhancing urine output within the first 6 hours. If I started earlier than the late norepinephrine initiation. The mortality rate, which is a secondary endpoint, was not different. The mortality was not different, but a lower rate of cardiogenic pulmonary edema and of new onset arrhythmia was found in the early norepinephrine group without a difference in the ischemic events. Taken together, these results suggest that early norepinephrine initiation was effective and safe. The optimal timing for starting vasopressors in sepsis has not been adequately tested since guidelines recommend fluid to be administered first. Some physiological reasons supported by the observational and experimental studies suggest that an early start of the vasopressors could be advantageous. And the benefits or harm of the early introduction of vasopressors, even preceding the initial fluid loading, remains unanswered. If I start the vasopressors even before completing the fluid resuscitation, is it beneficial or not? It's unanswered. And the prospective studies evaluating the impact of very early start of vasopressor support on the development of multi-organ dysfunction and the total volume of resuscitation fluids required during the early phases of septic shock are that's required. So give fluids first, give fluid first, give fluid first. A simple way to identify the patients who need norepinephrine urgently is to look at the diastolic arterial pressure, which is a good factor. If I check what the diastolic blood pressure, still the diastolic pressure is low, this means that I should be in hurry to start norepinephrine. As low diastolic arterial pressure is mainly due to a depressed vascular tone, especially in the case of tachycardia. Thus, measuring a low diastolic arterial blood pressure is, in this context, should prompt urgent initiation of the norepinephrine, even in the absence of the central venous access. How much should we give norepinephrine? Is there an optimal blood pressure target? Yani if my target to reach the target mean arterial pressure for the age, but shall I give higher norepinephrine to reach higher MAP, and is it beneficial or not? There is a physiological relationship between the organ blood flow and the MAP. Yani any organ perfusion pressure will depend on the MAP, which is generally regarded as the perfusion pressure of most vital organs. And the changes in the MAP will result in no change in the organ blood flow within a physiological autoregulation range of the mean arterial pressure. Nevertheless, below a certain critical value of MAP, organ blood flow will decrease along with the decrease in the mean arterial pressure. Autoregulation mechanisms are supposed to be impaired in septic shock, making the vital organs more vulnerable in the case of hypotension. Here, if we'll see this diagram, it will show the mean arterial pressure with the organ blood flow. If we see the blue line, with increment of the mean arterial pressure, so the organ blood flow, so our perfusion to the organs will increase till reach the autoregulation zone. After the autoregulation zone, when increasing the mean arterial pressure, yes, the organ blood flow also will increase, but is this beneficial to the organ or not? There is here, it will show there is a relationship between the organ blood flow and the mean arterial pressure. Targeting a mean arterial pressure higher than 65 millimeter mercury could reach an autoregulation zone. And once reaching 65, I will reach the autoregulation zone of the vital organs, which is seen by the blue lines. In the case of history of chronic hypertension, suppose this is an exception. If the patient has baseline hypertension, chronic hypertension, and was on antihypertensive medication and became in shock, there is a higher MAP target. We need higher MAP. Yani if the patient has no hypertension before the shock, we need to reach the mean arterial pressure target 65 to improve the tissue perfusion through the autoregulation zone. But if the patient has previously hypertension, is known case of chronic hypertension, I need higher MAP. So this line will shift to right. A higher MAP target may be necessary due to the rightward shift of the curve to enhance the tissue perfusion. Right. A large multi-center RCT that compared the two ranges of MAP targets, 65 to 70 versus 80 to 85 in patients with septic shock. And they did the studies comparing with, I want to reach the MAP and comparing with a higher MAP. they didn't show any difference in the mortality rate of 28 days. And the occurrence of serious adverse events did not differ significantly between the two groups. However, the incidence of newly diagnosed atrial fibrillation was higher in the high target group, about 7% of cases, than in the low target group, 3%. And a higher MAP target might be applied to some subgroups of patients. And in some patients, I need a higher MAP. And one of the trials showed that the benefits in terms of renal function. Some studies showed if the patient is chronic hypertension, I need higher MAP to enhance the renal perfusion and renal function, so I will avoid the renal replacement therapy. So some patients, it have benefits in terms of the renal function, including the requirement of renal replacement therapy, were reported in the subgroup of patients with chronic hypertension, when the higher MAP range was targeted. It is noteworthy that in this group of patients, no difference in the incidence of atrial fibrillation was observed between the two MAP target arms, because the patient was, his hemodynamics and his perfusions regulated on a higher pressure. Benefits on renal function are consistent with the fact that in the case of chronic hypertension, the organ blood flow and pressure relationship may be rightward, as we explained on the diagram, shifted so that a MAP value of 65 to 70 could not be on the autoregulation plateau. I wanted to reach the MAP, the target MAP below 65, the usual conditions to reach the autoregulation to enhance the perfusion to the tissues. Like in hypertension patient, no, I want higher MAP to reach the autoregulation. In summary, individualization of the MAP target is recommended. So not every patient like the others. We are tailoring the management according to the patient condition and his baseline condition also. The initial MAP value of 65 to 70 millimeter mercury in patients without chronic hypertension should be targeted. And targeting a higher MAP is reasonable in patients with chronic hypertension and in cases of elevated CVB, cases of increased intra-abdominal pressure. Yes, at that time, I enhance the MAP to be a higher level to counteract the effect of the higher intra-abdominal pressure, to maintain a good perfusion pressure to the tissues. In cases of doubt, of uncertainty, if we don't know if the baseline of the patient, a norepinephrine challenge can work out the best perfusion pressure to recruit the microvessels. And the skin perfusion markers such as the capillary refill time can be used to assess the effects of the vasopressor challenge. Is there a maximum tolerable dose for norepinephrine? The question of what would be the maximum tolerable dose of norepinephrine for achieving the MAP target is still not elucidated. Norepinephrine at higher dose, usually but not consensually defined as more than 1 or equal to 1 mic per kg per minute, is sometimes used as rescue therapy in severe hypotensive patients to reach the target 68 to 70 MAP. However, there is a good consensus among experts to start a second vasopressor in cases of refractory hypotension to prevent the effect of excessive norepinephrine load, which is named the strategy of decatecholaminization. Indeed, high doses of norepinephrine may compromise the host, the side effect of high doses of norepinephrine, like it can compromise the host immune system and promote bacterial growth, may induce myocardial cell injury and oxidative stress. So the higher, more than 1, can have a side effect on the patient, like immune system affection, myocardial cell injury, and the high mortality rates were reported in patients who received the higher than 1 microgram per kg per minute of norepinephrine in retrospective studies. Obviously, this can't only be attributed to the drug toxicity. The drug high doses is not explaining these changes alone, but can also be explained by the severity of the sepsis-induced vascular damage. Nevertheless, another retrospective study showed a 40% of 28-day survival rate in septic shock patients who received more than 1 microgram per kg per minute of norepinephrine for more than 1 hour. And the incidence of serious digital or limb necrosis was about 12% in the survivors. In addition, a retrospective analysis of a large cohort of patients has suggested that the short-term application of very high doses of catecholamine, like norepinephrine or epinephrine, does not influence the outcome. And if I given higher doses for short time, it has no influence on the outcomes. The results of the 2 later studies suggest that if the MAP has not yet been reached, the option of testing to increase the norepinephrine at doses higher than 1 microgram per kg per minute may be acceptable, especially when vasopressin is not available, as it is still the case in some countries. The question of adding low doses of corticosteroid here, if the patient is still not responding to the vasopressors, the question of adding low doses of corticosteroids, hydrocortisone, is still a matter of debate, as its influence on the mortality is controversial. However, there is a good consensus among experts to suggest low-dose corticosteroid therapy in cases of refractory shock, as there is evidence that its use results in earlier shock reversal in the patients with septic shock unresponsive to the fluid and vasopressor therapy. So it enhances the response of the patient to the fluids and the vasopressor therapy. For hours and a shorter norepinephrine administration. So earlier, the better. Conclusion. Today, norepinephrine is the first line vasopressor. This is the home message I want, especially our rotators, our residents, to know. Today, norepinephrine is the first line vasopressor in septic shock, and the epinephrine and the vasopressin remains the second line therapy in case of refractory shock. Early norepinephrine administration is recommended in order to achieve the initial MAP goal, which is 65 millimeter mercury for the adult, faster, and to decrease the risk of the fluid overload. The diastolic arterial pressure could be used to identify patients who need norepinephrine urgently. The optimal MAP target should be individualized, as it depends on the several factors, such as the history of chronic hypertension, values of the CVP, and the intra-abdominal pressure. In cases of refractory hypotension, increasing norepinephrine at high doses, more than 1 microgram per kg per minute, might be an option, although there is a current consensus in favor of adding other vasopressors, such as vasopressin. This is my references, and thank you. Welcome for any question.